So today we are hoping to spend just a couple slides on our mandate and make sure you're familiar with our sort of current activity levels, and then jump right into our patient voices. We then have some stats around some of the quality indicators that I thought you might be interested in terms of the sort of so what of all of that activity. And then, just like the Alzheimer's Society, we too have then structured some slides around your IHSP, thinking that that's the lens through which you view the world. So how do we fit in to those lenses? And then we should have lots of time for discussion, as Mary said. So, the Southwest CCAC, we are the home care. So unlike probably any other organizations you deal with, I think we are unique in the sense of being an entire sector that has been merged. So you deal with us for that in-home care. We are part of the home and community care sector, part of the healthcare system, so that's kind of how it nests in with where we fit in. And we are about trying to get people the care they need to stay well, to heal at home, and to stay safely in their homes longer. We help people transition through the system into other living arrangements, and all of that by working in partnership with clients, families, providers, community partners, and others. And there you see our vision statement, which is quite an aspirational one, and we're certainly not there yet. We've made a lot of progress. We merged, we're now in our 7th year. So there was a merger by government. It was not voluntary. It was a merger by government, effective January 1 of 2007, and just picking up on the last conversation, it would never have happened if there hadn't been legislation making it happen, I can tell you that. As a result of that, now 7 years later, there's been quite a bit of progress made with having that merged entity that happens to share your boundaries. So just to give you an idea in terms of some of the activities, about 60,000 people each year, which is 1 in 19, so that's kind of our penetration into the general population. About 1 in 19 people, residents in the Southwest, receive CCAC care. Our budget's just shy of 190 million, so I think we're either your 3rd or your 4th largest transfer payment agency, so we're larger than all of the hospitals except the London hospitals. About 2 million in-home visits in a year. You see there, any given day, we're touching in the homes, serving 20,000 people. We have about 700 staff on our staff as a CCAC team. And then, I think as you know, we then work with our contracted service providers. And we have 27 contracted service providers who are working with us. They employ the individuals, personal support workers, the therapists, the nurses who go into the home, and they employ about another 2,500 people. We do about 180,000 visits a month, about 2,500 discharges out of all of the hospitals that you fund, about 203 placements every month into long-term care. And we do have a single number to call right across the province for any kind of information referral, not just to in-home visiting services that we pay for, but it could be a call that ends up in the referral to the Alzheimer's Society and any of the other community agencies that was talked about earlier. And we get anywhere from 5,000 to 10,000 calls in a month. So a pretty large volume of activity, I think, relative to your health service providers, and we do share your DNA. So again, this comes to that unique piece. It was a very intentional government design in the mind of George Smitherman when this came forward after they were elected in 2003 to create LHINs and to sort of have our DNA come from yours in terms of the CCACs uniquely having the exact same boundaries as you, from Tobermory to Lake Erie in this case. And I think we are your only health service provider in which you can say that. We also overlap, or we also match your mandate in a lot of ways because we serve all client populations and ages. We sometimes say border to border, cradle to grave. And we do also work with every single health service provider. So we interact with all the hospitals on a very operational level, with all the long-term care homes, the community agencies, et cetera, et cetera. And we do have our care coordinators who are literally sitting in the patient flow. If patient flow was water, we are sitting where all the taps exist. We have care coordinators who get wet every day right in the midst of the patient flow, and who sit and who monitor that patient flow and are accountable for those transitions, frankly. So just to kind of make it visual, here are our offices that would have in the past lined up with predecessor separate organizations and now are all part of a single leadership team and single structure. And then I've overlaid now here the hospitals. We have care coordinators who work on-site, dedicated to every single hospital site in the Southwest, and you see them marked here. Is that a dog? We are also attached to and facilitate placements into every long-term care home, and so this map then now overlays that. We are present on-site physically with primary care, just as we are with every hospital. Our goal is to be present physically on-site with every physician in Southwest this calendar year. We're currently at about 120, and we've overlaid them here. If you're losing track of the dots, it's the little green triangle as primary care. So our goal is by the end of this year that there would be that many more dots on this map. And then we do have accountability to make referrals to Alzheimer's and all the community agencies. And just to pick up on that point, the piece that Betsy referred to in terms of that electronic referral that is now kicked in, you funded that. So you as a LHIN funded a dedicated resource. The technology was cheap. The technology was essentially free. It's just going through existing portals. But it's never the technology, right? It's always the change management and relationship building. And so you funded a dedicated resource that went literally to each of the community agencies and supported them in changing their workflow processes and enabling that electronic referral to come to life. And it's now being replicated across the province. So the other thing about the CCAC is not only are we only one for you to work with, but we are very closely connected like you are with your sister LHINs, we are with our CCAC. So if something takes hold in a place, we can quickly spread it across the whole province. And there is the overlay of our clients. So we literally have a client in every single nook and cranny of the entire Southwest area that we serve. So we work pretty closely with you, the LHIN, and with all of the health service provider partners on the transformation of the healthcare system. I would dare say we track your board packages pretty carefully, and there's lots of topics you're discussing that we're talking about as well. So we spend a lot of time thinking about how do we assist in the transformation agenda in the Southwest. So our board would have had extensive discussions of a generative nature. They're very much into generative governance, and always carve out at least an hour on every agenda for a generative transformational discussion, and would have had one focused on Drummond, on the action plan, on the senior strategy. And next week at our board meeting, we've carved out an hour on your new IHSP for a generative board discussion. And I think you'll see, as I continue to speak, the seeds of all of those reports, the directions and thinkings and visions, are incorporated into what we're trying to focus on and do. So we do very much support the provincial and the LHIN integration agenda through our work on consistency and integration. So by virtue of the merger, it didn't just make it bigger. As a result of that merger 7 years ago, we have achieved consistency across the Southwest so that if you are being found eligible for services in Tobermory, it's the same as if you live in London. The nature of the services you're getting are the same as they are no matter where you are within our boundaries. That would not have been the case 7 years ago. There would have been vast differences in that care planning in the home care sector. The LHIN planned and funds us. Sometimes people say, well, what's the difference between a LHIN and a CCAC? You may not have that question, but that's out there in public debate. So the LHIN is clearly kind of that, I sometimes say high beam, low beam, to quote Camille Forge, who you will know. She talks about high beam, low beam, that the LHIN is planning and funding at that system level. The CCAC is integrating care at that patient level. And we certainly work closely with the LHIN team. We are in numerous meetings and phone calls on a daily basis and spend a lot of time with your team and enjoy it very much. So we do act as that single integrated platform. We have a common electronic health record that we put in place upon merger, and that too has helped us with some of the data tracking, etc. And we've done that province-wide so that no matter where you're reporting from in the province as a CCAC, the data is comparable, gathered in the same way, and reported in the same way in connection with our LHINs. And it does offer that single service offering wrapped around the needs of clients. So I just have a slide here before getting into the voices of our patients on care coordination to understand what that is. We can think about our business as being the care coordination role, an assessment role, and then it's sort of what comes out of that assessment role, what services are put in place, many of which are through our contracted service providers that are paid for out of our budget as well. But there is also a set of outputs out of that assessment process that don't come out of our budget, so to speak, but are the other agencies you fund, whether that's Alzheimer's or any of the other numerous community support service agencies. So our role isn't just confined to the in-home visiting nurse or personal support worker or therapist that we pay for. We have to accept a greater accountability around system navigation to all of the services, and we're working very hard to do that as best as we can. So our care coordinators play a pretty key role, and they are all regulated health professionals. About 97% of them are nurses, are RNs, but they don't have to be. There are therapists and social workers as well, but they all have to be a regulated health professional. They do a holistic diagnosis. Sometimes the word assessment is pejoratively interpreted to mean administration. I'm here to say if there's one message I can leave with you, it's not. It's no different than when you go to your doctor. When you go to your doctor asks a series of questions and uses a series of tools, electronic and otherwise, as well as experience and judgment, an art and a science, in order to assess what's going on, in order to assess what needs to happen and who else needs to be brought into the care in order to achieve whatever the goal is that needs to have happen. That's exactly what a care coordinator does, but less of that thinking of the medical physician would have around diagnosing the cause of an illness. We are more focused on that holistic diagnosis to determine right care. So very much medical, absolutely medical, but also social, functional, emotional. We look at all aspects in that holistic assessment. It is done using a standardized tool that is electronic, and it enables us to have instantaneous algorithms around best practices, etc. as a result. They spend most of their time in the home, not at their desk. We measure that, and then do regular check-ins as well. So our more complex clients would be getting a visit once a week, every 3 months, every 6 months. The clients who aren't as complex would be getting a visit every 6 to 12 months with the in-home visits happening in between. So the types of services that we can bring to bear in the toolkit of a care coordinator, we have nurse practitioners, we have nurses, therapists, and personal support. The nursing clinics, we have 33 nursing clinics, so where it's more efficient in order to provide care that way instead of driving from home to home. We have 33 nursing clinics in the Southwest, more than in any other area in the province. We also mobilize and ensure resources in schools for our children with the School Health Support Services program, as well as new nurses that have been added to our team for a mental health and addictions enhanced resource for children with those issues. All the community support services, we accept accountability for making sure that all of those appropriate referrals are in place, and again, an increasing area of focus for us about how to do that better. I've already talked about primary care and needing to attach to those practices, and in the meantime, we do have the Healthcare Connects program in which we connect people who don't have a family doctor with a family doctor. So that's a program that's funded by you from the ministry through you into us, so that we attach orphan patients to family practices, as well as greater and greater involvement with pharmacies. And then in addition to that work, it's the placement work, that patient flow and transition work. So whether it's considering the move to long-term care or to CCC and rehab beds in hospitals, adult day programs, assisted living, supportive housing, as well as residential hospice, which I know you're talking about later today. And I wanted to update you. We do have our provider contracts where they are partners with us. We had been historically involved in an RFP process to select those. It generated a bit of contention across the province over the years. It was a bit of a political hot potato. But you should know that as of this past summer, we are now out of the RFP business. There was a policy decision made by government, and now all of our service provider contracts are indefinite. So I wanted to make sure you were aware of that. And we try to do all of this with our care coordinators with a client-driven care process and approach. We've been involved in more than 20 years of research with Dr. Carol McWilliam at the University of Western Ontario, with several millions of dollars of research grants from the CIHR in Ottawa around how involving an approach of do with instead of do unto with clients and partners can lead to improved health outcomes and improved system outcomes in terms of fewer days in hospital. So now, not me, let's hear what our patients say. And let's see if this works.
You don't get on the phone now because they're coming to you first, and what can we do for you? should have people in here for maybe a month. Well, take all the help you can get, but don't pay any more than you need. There's other people sick with the meal there. I've always said that. Real sick. But Derek said, no, they're all important to us. But I said, people like Derek, they don't come along on the show too often. I don't know. The third one in a million. And I said to my wife, if we ever get a divorce, I'm going to ask Derek to marry me.
One is to give you a moral support for one thing. You come and trust them that they're not going to drop you on the floor if they get up. And just generally make you feel secure, I would say.
There's no way of me learning because they taught me all these things. It started right there in CCAC. They are the one who came over and taught me many things, including getting into the house using a ramp. Right from there, they started using it. So they taught me quite a bit.
I don't like going to hospitals and stuff, so it's nice that they come in and the nurses and, I don't have to go to the hospitals and stuff like that. And I found it a lot better. I find it a lot better.
The case manager is the person that I can call if I have any questions, any concerns whatsoever. She's there, and we have the best case manager. If anything needs to happen quickly, it does. I just can't say enough about the people that work with us. We've got the cream of the crop. I know it.
So, and just to explain, that the last woman who spoke is from Wyerton. Her husband was on the EShift program that you funded, being a program that started in Grey Bruce that enables palliative care clients to get 24/7 care in a much more cost-effective, and human resource-effective way. And that was a quote, and that was one of your LHIN Quality Award winners last year was on that EShift program, so I just wanted to make that link for you. So I know you have questions around how does home care and CCAC fit in and the community support service agencies. You're not the only one asking those questions. We're asking those questions. The province, the minister's been asking those questions. It's in part why Dr. Samir Sinha has gone around the province and has developed a senior strategy. We only have the executive summary so far, but we have a pretty good glimpse into that report. And so I wanted to ground for you in some of his visuals, kind of how we think we're seeing the world that is aligned with his thinking. So all CCACs across the province are moving to a population-based approach, which means, if I can use the triangle, I believe you're familiar with this idea that there are more clients. If you look at the 1 million people who live in the Southwest, there are far more that live here. Those who use the healthcare system, their cost per episode is very small, or their cost per person is very small. As you go up the triangle and become more complex in your healthcare needs, there are fewer of you, but your cost per episode or your cost per year becomes much higher at the top. Certainly those sort of high five we talk about of the 5% of the population that can consume 50 to 80% of the cost, depending on how you look at those calculations. In recognition of this, going back 18 months ago, the CCACs thought, we're living in our archaic way of organizing our services. We're past the worst of merger now. We need to lift up our head and understand there is this tsunami of complex and chronic clients, dementia clients coming forward. How are we possibly going to do more with the same, if not more with less? And part of that was around, we can't just organize ourselves by geography anymore. So we can't just have a care coordinator who's accountable for this section of Owen Sound and all the clients in that area are her accountability. We have to change to a population-based approach so that we can better focus and triage our resources and frankly move our resources up the triangle. Are we spending too much time here? Because this is where community support service agencies need to come to play in a better way, and in terms of increasing their capacity. That's what they want. That's what Dr. Sinha is talking about. And are we becoming more the acute part of the community, if I can call it that? So moving to a population-based approach, as of March 31st, our last set of stages is kicking in the next several weeks. All of our care coordinators are no longer by geography, and they are now assigned by population type. So there are care coordinators who have smaller caseloads now who only focus on complex clients. And they provide very intensive case management for those clients. They may only have 30 to 50 clients on their caseload, for example, but that's because they're going into the hospital before they come out. They're literally at the bedside in the care coordination conference. They're going with them to their first appointment with the family practitioner. They're in the home when they get home or within 24 hours. And they may be in the home 2 to 3 times that first week and then follow up on an intensive level thereafter. And same with clients who are care coordinators who are supporting chronic clients. And when we come to the community independents, in contrast, they may have caseloads that are more than 200 or 250 on their client caseload, but it's a very different type of care coordination. It's really focused on professional services, but then involvement of the community agencies in a much more focused way. And so when we think about, when I look forward over the next year, I see that the combination of the e-referral technology that Betsy referred to, as well as this focus, intentional focus by population, I think we will see an even stronger link and working relationship with our community partners. And when I go beyond operational changes we are making, when I look at Dr. Sinha's executive summary of his report, at least in the senior strategy, he talks about one of his recommendations is pretty explicit around a collaborative model. So we welcome figuring out what that would look like in the Southwest. You may know about new regulations that are coming, and we've seen them in draft, and the LHINs have prepared a response, as have the CCACs and others, into government, so they're not yet finalized. But they put a sort of a line in the sand, so to speak, in regulation, now in law, that will make it much clearer around people who only, more clients that are more independent, who only need personal support, instead would be provided their services through community support service agencies. The CCAC would remain involved for some of those clients if they need professional services as well. So, for example, ongoing nursing visits. So you will continue to see this sort of shift happening. It has to be worked out with the LHIN, it has to be worked out collaboratively with all of our community partners, but you will continue to see us kind of moving up the triangle and becoming that even more that acute part of the community, and the community agencies therefore being able to increase their capacity in order to provide support to the community independence clients. This is going to take a lot of work. Work on the ground has already begun. But we, each year as a CCAC, host a partner event where we get all of our care coordinators in one room and we invite in one of our stakeholders for shared learning and relationship building. So one year we had all long-term care homes. Another year we had all the adult day programs, assisted living and supportive housing providers. That was last year, given the access to care work that was happening. This year, just as of Monday, we confirmed that Dr. St.Mary has agreed to come to our event this year on May 6th. And we will be inviting all of our community support service agency partners and hope that they will come. And that we can have an on-the-ground opportunity to hear his vision, explain what he sees as a collaborative model, and then turn off the microphones from the front of the room and unleash people to meet each other and to circulate around a room working through client scenarios to get role clarity on a client service planning initiative one by one on what should the CCAC role be and what should community agencies be. So I think we'll see good progress on this through the year. Now, to some of the so what that I know our board holds our feet to the fire on, and so I'm sure you do as well. So there is a sector quality report that the CCACs prepare each year. It's on our website if you're interested. We're across our entire sector. We're reporting on our outcomes. Locally, we prepare a quality improvement plan every year. We are fully compliant with the Excellent Care for All Act, even though it doesn't apply to us. We are fully compliant with it. And each year we do a quality improvement plan. We set targets and measures, and we report on those publicly on our website. We have a whole different contract template that was put in place as part of the No More RFP policy change by government this summer. And part of that includes more rigorous quality reporting standards, and that reporting will not just be to the CCAC, but will become public. So there are plans in place for that to happen over the next several months. We're also moving forward provincially with standardized care pathways. There are currently 11 that have been developed. I was at a meeting yesterday, we approved another 10. And that will come with it not only standardized care pathways so that every CCAC is providing the same care that is evidence-based, but also moving to an outcome-based reimbursement model, whereby instead of paying based on the number of visits that a provider does, We wouldn't be paying that way. We would be paying once you heal the wound. So whether you do 5 visits or 15 visits, we're not going to worry about anymore. We will pay when you prove the wound is healed, as one example. We also measure patient satisfaction on a quarterly basis. We use the same tool across all 14 CCACs. We have, if not the highest, one of the highest patient satisfaction rates in the province, and you'll see our most recent result there, 94.4%. We have gone through accreditation. All 14 CCACs are now accredited. Ours was last fall, and we were thrilled with accreditation with exemplary standing. In terms of our quality improvement priorities this year, we will continue with Home First, and I know you know lots about Home First, and you've got more material in your board package today on that. Continue with implementing that coordinated access to CCC, rehab beds, assisted living, adult day programs, supportive housing. I know you know about that. This integration with primary care is a big one for us. Having on-site care I couldn't imagine in a hospital setting like this, take St. Mary's, expecting the referrals to come up to us right if we weren't here. And if we were just a black hole at the end of a phone or a fax machine. We'd never get the right referrals out of this hospital. It happens because we have a care coordinator who comes here every day and who is a member of this team. Well, that's what we need with family docs. And so making that shift this year to have on-site with every single family physician and the further integration that's going to come through health links, I think is going to be a big, I think the big dots are going to move this year. IVs and medication management, an important part for us. Wound care, always working at wound care. We spend a lot of money on wound care, and it's not all best practice. And where we have implemented best practice, we have saved a lot of resources. And across all 14 CCACs, we're engaged in an initiative called Transformation Begins at Home, whereby we are looking at our processes and our electronic e-health enablers to even more eliminate any of the paperwork. So I have a slide to share with you in a couple of slides where we are about 4 months away from having every aspect of our transactional business electronic now. I think you might be interested in wait times because the NDP has put that in play with the expectation that to get Ms. Horvath's support, Premier Wynne needs to guarantee a 5-day to home care wait time so that nobody's waiting more than 5 days. So I wanted to share with you, you might be curious, so what's our Southwest CCAC stats? So we have no wait lists for in-home services. That's not the case across some other parts of the province, but we do not have any wait lists for in-home services. We do have a couple of hundred children who are on wait lists for school therapies, but we do regular wait list release every 3 to 4 months. We have, in terms of the service wait times, if you're coming out of hospital, how long do you have to wait to get a visit? A lot of our patients, 50% are seen the same day of hospital discharge. And if you want to say, well, yeah, but what about this 5-day wait time guarantee? We're already at 91%. So 91% of all patients coming out of the hospital supported by us would have a visit from us within 5 days. So we welcome the 5-day guarantee. All we've asked, and I have met with both Ms. Horvath and Teresa Armstrong, the local rep, on this point, was it can't be too robotic. Because some of our patients coming out of hospital don't need a first visit in 5 days. Some of them are very intentionally scheduled for after that. That accounts for a fair bit of the difference between 91% and 100%. So we just have to make sure if suddenly people who don't need a visit are forced to get a visit within 5 days, that's going to screw up our human resources in terms of people then having a nurse available when they really do need that visit within 5 days. So that's been our point of emphasis with the NDP firm. So, this is the e-health slide. I have no intention of explaining the whole thing to you. You'll be glad to know. And this is not a picture of the Southwest system. This is just transactional, looking at the CCAC to paint the picture for you. And because, frankly, you guys have funded some of this. So, through Home First, there has been funding for electronic notification screeners and e-referrals that is now in place, so that all aspects of our transactions back and forth with hospitals who have implemented this is now fully electronic. No more paper floating around. In terms of, if I go next to e-referral, because that's been mentioned, we are about to implement in the next 3 months an e-referral enabler that would make electronic the referrals that we will be doing and have started doing with CCC rehab, assisted living, supportive housing, etc. When we look at our contracted service providers, that has been paper-free for many, many, many months now. And now what's extended, and again, this is the piece you paid for, which is the e-referral to community agencies. You didn't pay for the technology, but you paid for the project management support that made it happen. We will be within a few months of having the process to long-term care become entirely paper-free. And it also is available paper-free with mental health and addictions. When I come back over here, I've talked already about the fact when our care coordinators are in the home, it's all electronic, it's paper-free, and they can make referrals right from the home. They are mobile and fully set up with technology that's live in the home. The part that's on the only arrow of a transactional nature that is in black for a reason, because this is the piece that the healthcare system we have to solve. We do not have many electronic enablers between us and primary care. So the SPIRE project, which I know you know a fair bit about, has made the physician to hospital link blue. It's made it electronic. There is a possibility for it to make this part electronic. There are other pieces that are in the work across the province as well. But this is the last great piece that needs to be solved, and then we would be entirely electronic. So now turning to your lenses around the IHSP, the first one around improved access to family health care. I spoke about Healthcare Connects just so you have an idea. That program has had a huge impact. So more than 19,000 people in the Southwest who did not have a family physician now have a family physician. So we match more than 80% of the people who sign up for that with a family doctor. I talked about needing to get on site with every family physician in the Southwest. There's our current number, and our number for the year is to complete that with all of the other community physicians. You should, hopefully you've heard about Partnering for Quality. It is an initiative that you fund. Through that, Partnering for Quality, there are on-site resources that go into primary care, and we all hear and see stats that said they have electronic health record. The quality improvement and e-health coaches then get into that family health team, and it finds out that all it's used for is billing. It's actually not being used to drive best practice or to generate the kind of data. You can't manage what you don't measure. And it's not doing the kind of measurement and management that needs to happen. So you're funding coaches that go in and do that quality improvement coaching and electronic record coaching to change that around so that they are driving a quality improvement agenda through primary care. You know about the Southwest Primary Care Network. We have a seat at that table with those physicians. And of course, HealthLinks is a very exciting initiative. There are a number of pieces falling into place through HealthLinks all at the same time, so that the service promise we are making to those HealthLinks is that not only will we have the care coordinator on site with every physician, but we will also provide intensive case management support for those complex high-five patients. We will guarantee a visit same day at a hospital or from referral from a physician through a rapid response nurse, and that they in turn can deploy this whole basket of services that are necessary to wrap around the high-five patients. So improved coordination and transitions of care, we kind of live in the heart here of this piece. You know about Home First, more than 700 clients a month who are have been shifted their care out of home, or sorry, out of hospital and in the home instead. About 30 to 50 of those are on 24/7 service plans. That did not exist a year and a bit ago. And so those 24/7 care plans have been essential. They can only be in place for 3 or 4 weeks, because we would go bankrupt like that if they lasted much longer. But that bridge, that intensive supports of that bridge, it's remarkable. 2/3 of the people in that time are stabilizing enough such that they are no longer in a crisis mode in hospital saying, I can only go to long-term care. They've stabilized enough such that they can see a different path forward and can be supported with community resources and regular CCAC in-home resources to stay at home. So there's been a significant reduction in ALCs. It differs by hospital, but there's been a reduction in ALCs overall, and especially in the ALC subcomponent called long-term care. So you can see these are the Home First hospitals together, their ALC long-term care data, and you can see the high and you can see the low. These labels are when those hospitals kicked in to the Home First program. The intensive home care team that I mentioned, those are those practitioners and rapid response nurses. They track very carefully on a data basis the clients that they are seeing and supporting and the hospital avoidance. And up to the end of Q3 in December, there were over 2,500 clients who avoided hospital as a result of their intervention. You know about the access to the coordinated access. The other pieces I've talked about in the interest of time, I'll keep going. In terms of safety through evidence-based practice, a wound care initiative, again funded by the LHIN across all of the hospitals, across the CCC, and across every long-term care home to implement best practices, to use standardized products, and to shift that forward. That for us is amounting to a $350,000 savings per year. Gord leads that for us, so all your detailed questions he will answer. Falls prevention, you fund Grey Bruce Falls prevention with the Grey Bruce Health Unit. We happen to be a partner in that project. As a result of a comprehensive assessment that our care coordinators in Grey Bruce are doing, connections with EMS and other very, very cool initiatives up there, they have documented 47% fewer falls. In terms of the value and value for money, our board spends a lot of time on this with us, and so there have been significant consolidations and efficiencies as a result of merger itself. I could talk for days about the merger story and the benefits that have come out of that and the proven dollar value, savings and effectiveness and efficiencies. But to give you a more recent example, we are still in the business of issuing an RFP for our medical equipment and supplies. We just did that, and instead of having, is it 15 providers or more from Tobermory to Lake Erie on our medical equipment and supplies, we now have 2. One doing all of the medical equipment from Tobermory to Lake Erie, one doing all the medical supplies from Tobermory to Lake Erie. And we anticipate saving at least $2 million this year as a result of that RFP. And I've talked to you about the 33 clinics that we have, so that clients who are able to go to a clinic receive their care that way instead of the nurse driving from home to home. Again, quite a cost savings as well as an HR savings. The admin of CCCs is talked about a lot. Mostly it's wrong based on misinformation. Our admin is 3.9%, so we put that up against anybody. The e-health enablers have been critical to us getting to that place of efficiency and effectiveness. I've got to mention EShift again because it is it has been recognized by Accreditation Canada as a global best practice. It won your LHIN Quality Award last year, and it is being spread now across 4 other CCACs in the province. You should be very proud of EShift. And as well, Healthline. You've been a supporter of Healthline, that single source of truth of all services. If you want to have better integration and awareness of healthcare and people not falling through the cracks, you've got to start with an accurate, user-friendly list of all the services that exist. And that's what Healthline is. So we're happy to have any discussion you wish. Some questions that we thought of with our board. Do you think home care matters? Why do you think it matters? What's your vision? Any thoughts you want to share, priorities, or do more of this, less of this? Any of that you want us to feed back? Our board members are here, and we will take it to our meeting next week. What do you think if our mission is around outstanding care every person every day? If you have any thoughts on that. But also anything else we can be doing to support your priorities, and if you have any wish for any follow-up information, we're happy to do that as well. So fire away.